So really sorry for not being there in person today, but I'm very grateful for the organizers for the invitation. So my background is in statistics, and my group works on biomedical data science. So our work focuses on developing, applying, and implementing new types of statistical methodology to different types of complex biomedical data. And today I will talk about a specific project, which is a large-scale collaboration with Public Health Scotland, the Alan Turing Institute, the University of Edinburgh, and Durham universities, where we are developing large-scale machine learning approaches to predict the risk of emergency admissions in Scotland. So why do we do this work? Well, there was a historic motivation for this project started in 2005 from the CARE report, which highlighted the need for the NHS to focus on proactive care, anticipatory care, to try to prevent health crises from happening before they occur. And Public Health Scotland took, within this context, emergency hospital admissions as a particular target for intervention, because emergency hospital admissions represent a breakdown of the control of health in which a patient urgently needs a very acute care that can no longer be managed in primary care. It needs to be done in secondary care. And patients that have an emergency admission in Scotland tend to have longer admissions and worse outcomes than in comparison to planned admissions. So, well, that's the motivation. Now, what is enabling us to carry out this work? Well, is the richness of data that we have in Scotland. As many of you know, we have a very rich national healthcare databases of electronic health records, which really enable us to track the healthcare pathway for everyone in Scotland from birth to death. And the project I'm talking today is called SPARA, so it's called Scottish Patients at Risk of Readmission and Admission, which, as I say in my introduction, aims to predict individual level risk of being admitted to the hospital as an emergency inpatient now within 1 year from the prediction time point. And as you can see in this cartoon, while the overall goal is that if we can predict this risk, we can provide this to GPs across the country, and indeed Public Health Scotland has been doing this for many years. Monthly GPs get these scores, and they can use these scores in order to plan anticipatory care that eventually, hopefully, prevents some emergency admissions and leads to better improved outcomes and longer healthy life expectancy. And from the historic side of this project, there have been many different versions of SPARA. So the earliest development dates to 2006 from Public Health Scotland, and the score has been developed many times by updating the coverage. So the current version of the score is SPARA V3, which is currently deployed in Scotland. It's calculated monthly for basically 80% of the Scottish population, which includes everyone who has had interactions with the health system, basically. And around 2017, we were tasked together with a team of researchers from the Alan Turing Institute to explore whether we could use modern machine learning approaches in order to improve the performance of the SPARA score while retaining interpretability and having into account at the core of all of our work, reproducibility. So this is what we did. So in terms of data resources, we have been working with data for about 5.8 million patients in Scotland. So you can see it's a very large number of records comprising everything from A&E admissions, outpatients, prescribing, and so on. As you can see here, this is just a very high level summary of the data. You can see that we have, when we look at the distribution of the number of records, you see patterns that you will expect in this type of data. For example, for females, you see a peak in terms of the number of records around the age of a childbirth. So if someone has a baby, you tend to have a lot more interactions with the healthcare system. And we also see some interesting patterns in terms of how the number of records relates to deprivation. And you can see that it's slightly increased number of records for patients or individuals in low socioeconomic deciles, as designed by the Scottish Index of Multiple Deprivation. So Of course, we need to manipulate all this data. All this data has not been recorded or collected for the purpose of research. It has been collected as part of patient's care. So we had to manipulate this data to bring it into a format that is suitable for a data science or machine learning project. So what we have decided to do is to consider a pre-prediction at any kind of prediction time cutoff. We consider a pre-prediction time point that uses information from past medical records from patients, ranging from 1 to 3 years, depending on the data that we are using as an input, with the exception with long-term conditions where we use data from the start of the records that goes back to 1980. And the prediction horizon is 1 year. Here you can see a little bit more information in terms of our inclusion-exclusion criteria. So the final score, we are basically working with around 4.2 million individuals, 4.8 million individuals, sorry. Again, in terms of data preparation, there are many modeling choices to be made in this context. We have decided to model as a target a binary indicator that indicates whether someone died or had an emergency admission within 1 year from our prediction time cutoff. And there are many arguments in favor or against this choice. We could have them a bit different, but this is what has been done very similarly in previous versions of Aspara, and we wanted to stay closely related to what was done before. And in terms of example predictors, we have derived things like the time since last emergency admissions, the number of prescriptions filled, age, deprivation. All of these features in general were features that were used in previous versions of Aspara and were manually curated by a team of public health experts and DPs. Something to emphasize is that there is data that we don't have and that will be really important in this context. And in particular, we don't know things about smoking or, for example, broader primary care information, which is not currently collected at the national level in Scotland. As you can see here, we have around 1 million events, 1.1 million events in all of our data set. So I'm not going to go into the details in terms of the pipeline that we have implemented. This is a relatively standard application of machine learning approaches that are out of the box, unlike most of the research of my group that focuses on methodology. This has been a very, very applied project in which the main context for us is to make this as a useful tool in clinical settings rather than develop new methodology, although as I will talk you a little bit towards the end, this has also spinned out some methodological problems. So we use the data sources that we have. The first thing that we do is we use a topic model, which is enable us to summarize the information that we have in prescriptions and past hospital admissions records in terms of diagnosis. And this really enables us to capture some more granular information that was in previous versions of Aspara. And we think that the features derived from here can be interpreted as a proxy for multimorbidity patterns. And for the rest of the features, we basically derive a design matrix that is suitable for a machine learning approach. Then, rather than selecting a single type of machine learning approach, we apply a range of different approaches, going from logistic regression to neural networks. And rather than selecting a single one, we combine those into a single prediction by a super learning ensemble, which basically weights each of the constituent models, each of the specific models based on their ability to predict the outcome. And these outcomes will be calculated and distributed monthly by Public Health Scotland to GPs across the country. So in terms of overall performance, you can see here, so these are standard figures of AUC and precision recall AUC that are looking at discrimination. We can see that we have some improvement with respect to version 3, which is the previous version of the score. And very importantly, in a clinical context, our score is quite well calibrated as well. Now, many of you will look at these very small numbers of the differences in terms of AUC and say, well, so what? Well, once you are calculating these scores at the national level in a population of about 5 million people, those very small increments in AUC translate into large numbers of actual patients that might be impacted by the change of the score. So, for example, here what we did was to rank among those, for example, the 50,000 patients with the higher risk scores. what's the difference of numbers in terms of patients that were actually admitted as an emergency inpatients, and you can see that the new version of the score can recover around 4,000 or 5,000 patients more than what was done before by the previous score. So this is just looking at the top 50,000 patients. If you were to extrapolate this when applied to a national setting, this really translates into large numbers. We have also done some kind of rough calculations that I will not go into detail in terms of how many interventions, so how many patients the GPs will need to act in order to prevent emergency admissions. There are many assumptions that we need to make in this context, but again, the bottom line message is that with the new score, we might save or prevent more emergency admissions than before, and ultimately affect a large number of lives. We have done a large number of model analytics. In particular, for example, here we are looking in terms of interpretability and what is the contribution of different factors. You can see here these two plots show the effect of age and deprivation as defined by the deciles of the SIMD index. And you can see one very striking result is that the differences in terms of risk scores contributions that we see for age and SMID can be compared. So the difference between being roughly 40 to 60 or 70 years old can be compared to the same difference that you will see between several SIMD deciles. In other words, people who are in more deprived SIMD deciles tend to have risk scores that comparable to those who are much older in the least deprived sections of the population. In terms of what we can predict, is also important to analyze. So what we have here is, so each of these lines, the colors are representing different kind of cutoffs for the probability. So if we were to decide that someone that has a score of, for example, 0.1, whether they will be admitted to a hospital, yes or no, you can see here is the distribution of the time to event. So how soon they will have an emergency admission, and you can see that people who has the highest risk score tend to have an event earlier than those that have a low risk score. So part of the SPARA scores are predicting the imminence of emergency admissions. We also look at the overall distribution of the scores for those individuals who had an admission and for those individuals who didn't have an admission. And well, when we stratify these, depending on the type of emergency admission as defined by the diagnosis that was assigned to the patients once they were admitted to the hospital, you can see that there is high variability in terms of the admissions that can be predicted by SPARA. Now, remember, we have not using the model any information about the type of admission. We just have a generic outcome that compresses all types of emergency admissions together. So this is to be expected. There are certain admissions that are much more predictable than others, and for others, for example, obstetric admissions, we really think that we'll need to have a more targeted approach that uses features that are very specific to the type of admission and perhaps data that is not used currently in the SPARA score. So beyond model development, I think one very interesting problem that we encounter when working on SPARA, it relates to the use of the idea of model updating. So if you think when SPARA version 3 was developed, we had a situation, or we can think of the graph that we have on the top, where we had certain features, X, like age, deprivation, or past medical history, that might have been affecting the risk of emergency admissions. Here we are using Y to denote the outcome of emergency admissions. And both of these informations, these X and Ys, were used in order to train SPARA v3. Now, when we are training SPARA v4, we're a slightly different situation because SPARA v3 already exists and is calculated for 80% of the Scottish population. So potentially, if GPs made an intervention based on the SPARA v3 scores, this will alter the Ys that we observe. So imagine that SPARA version 3 highlighted a patient to have a high emergency admission risk because they were under a particular medication. Well, GPs could have seen this and perhaps take the patients out of that medication as an intervention. Now, if that was effective as an intervention and prevented an emergency admission, what we will have seen in our data is that y is going to be equal to 0. There was no admission. So the setting in which we are training SPARA v4 is completely different to the setting in which SPARA v3 was fitted. And this is something that more broadly in the literature is called performative prediction, when existing risk score might affect the outcomes or the data that we observe when we are developing a new risk score. And we have a paper a couple of years ago in which we did some theoretical work around this problem, and there is some follow-up work that we are doing in this area. The other ongoing project I don't have a lot of time to talk today is, well, we know in Scotland there is a strong high inequality. So here is the map of Glasgow, and you can see that there is a big life expectancy difference even when within Glasgow by taking the tube. If you go from one station from, I believe it's from around Brighton, if you go from there to Jordan Hill, you can see a high difference in terms of the healthy and the life expectancy of the population. So one of the things that we are trying to do right now is to evaluate the performance of SPARA, but now try to identify whether we have differential performance across different groups as defined by age groups, deprivation, geographic location, so we have people from rural or urban areas, as well as ethnicity. And the write-up of these results is work in progress, and we are also working on a dashboard that will be uploaded into BHS website so that people can look at this data and try to interpret the SPARA context scores in context. So ongoing future work, one of the key things is deployment. As I said very earlier, reproducibility is very important, particularly it's generally a problem in machine learning, but it's a particular problem when you are deploying things that can potentially affect people's lives. So we have done very thorough reproducibility checks to ensure that all what has been developed, the score was developed in the IDRIS data Safe Haven, is comparable to what will be deployed by Public Health Scotland, which is deployed in their own IT systems. We also hope to assess the evaluation of impact. So once the score is deployed, can we quantify what is the impact on the actual impact in vivo, not in silico with the cross-validation or what we can do with the data we have? What's the impact that we have in patients' lives in terms of outcomes, for example, in terms of length of stays, healthy life expectancy, and so on. We have also done some public engagement work. In particular, we have worked with the Health Data Research UK PPIE group in order to derive accessible descriptions that we are going to incorporate in our dashboard for public dissemination. And one thing that we are really interested in terms of data drift and what happened with the pandemic, how does that affect our model, and do we need to update it again? And I see you standing, so I think it's time. So it's perfect because it's my acknowledgement slide.